Hello, and welcome to the Body Fusion Therapy Podcast. I'm your host, Dr. Heather Demirci. In today's episode, I'm going to talk about a saying that I came up with, and I think it really sums up my view of how I treat the body. And that is specialization stifles imagination. As soon as people start to specialize in one area, regardless of the profession, they become turned off to the possibilities and different ways of thinking. Now, don't get me wrong, it's really important to have specialists. We need to have specialists. Like if I had a brain tumor, I wouldn't want to go to just a general surgeon. I would want to go to a neurologist and a neurosurgeon who really knows what they're doing so they could target and get to that area. But that's for really specific things. We also need generalists. And I love how organizations are starting to bring in employees of seemingly unrelated fields because it brings in a fresh perspective and an injection of life into the organization. I know people that have studied psychology and sociology, and they were hired by tech companies because they just brought a different perspective than these people that were so specialized into technology. They needed to have an outside view of how different ways can work. Because when you just become so myopic, so nearsighted into that one area that you focused on, it's really hard to see that there are any other possibilities. When really, there's a multitude of different ways to do the same task, and not one is the right way. There are different ways to look at it. So when you're looking at the body, I think it's really important that you don't just specialize in one area, that specialization is going to stifle your imagination and your ability to look at the whole person and understand how the whole system works together. And this isn't just for healthcare practitioners. Patients too, people that are struggling with pain, you need to understand how it all works together. You need to understand that there can be components coming from different areas that might be leading to where you are right now. And unfortunately, you might have to be an advocate for yourself to kind of figure out what those other areas could be that could be affecting where your pain is right now. So I think it's really important to keep an open mind with your patients and then also with yourself as to what could be working for the body and against the body. So my objectives today in this episode is to discuss how the body works together and that it can't be just separated into part always. Sometimes it can, don't get me wrong, like I said, we need those specialists, but it shouldn't always be separated. The need for critical thinking, and then why I don't always pay attention to what the medical diagnosis is. The body works as one unit. It all works together. That nursery rhyme of the knee bone's connected to the hip bone, it's really true. The body is all connected together, and you need to understand that and assess the whole body, either of your patients or of yourself. I think that this is, especially in the United States, we have this society of not really liking the generalist or your primary care physician, that they're just kind of, a one stop before you get to the specialist. You just want to see the specialist. But in other healthcare systems, like over in Europe, it's the general practitioner, your primary care physician, that is the number one person, that they're the one taking in all the information from the different specialists to come together to bring this whole picture of why you're struggling with whatever you're struggling with. And there needs to be more of that. It shouldn't be such a focus on if someone's a specialist, then I have to go see them. They're going to understand it because honestly, there's going to be parts that they don't understand and they don't get because they're specialized in that one area. They can't tell you that there's a problem elsewhere in the body when they just specialize in their one specific zone. I recently posed the question on my Instagram page if people knew what I was talking about when I said the hierarchy of the organ systems. And it was kind of split 50-50. So I want to make sure that everyone on here on this episode understands this hierarchy of the organ systems. If you want more in depth, go back to my episode 1, where I go over it a little bit more succinct to understand the thought process behind all of it. But I want to also bring this up is that there is a hierarchy to your organ systems where the two most important organ systems are your nervous system and your cardiovascular system. Because without those two working, without your brain working or your blood pumping, you are considered medically dead. So those are the most important organ systems. And then it kind of goes down from there. I'm not going to say that one is more important than the other in terms of your vital organ systems. I would have to say at the bottom of the barrel is your integumentary system or your skin. And then above that is probably musculoskeletal system. Everything else above there is more of a vital organ system that you need to have functioning properly. Now, the reason why I bring up the nervous system and the cardiovascular system is because they run throughout your entire body. You can't find any part of your body where you don't have blood coming out if you poke yourself, or if you can't find a nerve or feeling, sensation. Those are all nerve endings. So if your nerves or your cardiovascular system, the vasculature of your body, are at all inhibited, it's going to affect how your body's moving and how your body's functioning. It's all one unit. It's all working together. There's also this idea of kinetic chain. So the kinetic chain is, as we go through, is like as you're walking and you're stepping through your ankle, and then pressure's going up through your knee and then through your hip and into your pelvis, up your spine, and kind of working all its way up. So the idea of the kinetic chain is that if you have these uneven surfaces or you have these dysfunctions that are causing torsionings through the body, then you're going to have breakdown. So as an example of this, the knee is like the dumping ground for dysfunctions of the foot and the hip. Very rarely is knee pain truly caused by an issue in the knee. It's usually caused because of an alignment issue being affected through this kinetic chain, and as your body bears weight through either the hip or the ankle. So to really treat the knee, we need to treat the hip or the ankle. In most cases. There are obviously exceptions, and it could be going way up even higher or way down lower. But there's this idea of how your body takes pressure and how it moves through life and against gravity, and how it's affected by if things aren't in the right alignment. So if I came to a knee specialist and all they did is focus on my knee, they might be missing this picture of a hip dysfunction that I have going on, or that I have, too high of arches in my foot, and that's causing a weird twisting of my tibia or of the bones of my lower leg. So if you're only focusing in on the site of pain or the site of, what your quote unquote injury is, then you could be missing the whole big picture here. Like, let's think about a golf swing. As everybody's summertime, everybody's getting out more and playing more golf. Hip mobility is a huge component to back problems with golfers. If you look at Tiger Woods back before he had his first back surgery, you'll see that he has beautiful internal rotation of both hips, because you need internal rotation on both sides of your hips for the backswing and the front swing. So you need to have good mobility of the hips, and then that pressure that has to go through that whole twisting motion to kind of wind up the shot and then follow through, you're able to disperse it evenly throughout all the segments. If you have a breakdown, like he started to then work out a lot more and build a lot more weight, and it seems like from what you can see on his videos right before he has back surgery, that his hips no longer have that internal rotation that they need. And this, all of that torsioning that has to go through for him to hit that good shot has to go through his lumbar spine. This is what I talked about my episode on the root cause, which was episode 10. Where I'm talking about this hypomobility versus hypermobility. So this area of not enough motion creating an area of too much motion. And that area of too much motion, you're tensioning all of those ligaments and soft tissues. And that's usually where the pain is, because you're pushing those tissues back past what they could normally do. And then it's what causes pain. But if you want to treat that and want to get it better, you usually have to treat the area of hypomobility, not enough motion, to be able to cure the hypermobility and decrease the pain there. So this idea of the kinetic chain and how everything's wound up through your system is really important, and how everything travels through. And you have to look at the whole body. This is also with coordinated movement, this interplay with movement and coordination of that movement. So like with walking, I don't know if you ever notice when you're walking, if your right leg is back, then also your right arm is back. And as your right leg swings through, your left arm swings through. There's this kind of cross-body motion that's occurring, and it needs to happen to have coordinated, good core activation to get you to walk and move your body through space and gravity. A lot of runners will say that it was their shoulder, that they needed to get better shoulder mobility to fix their opposite hip issue because they overcompensated by trying to swing that leg through because there was something not happening right with their opposite shoulder that wasn't allowing them to coordinate this movement and work it together. So the body really is all connected. It needs to be able to move efficiently, and that includes muscle activation. So you can't just view the body as just that one side of pain. It can't be that ceiling tile. I was talking about the leak through the ceiling tile. You can't just assess that ceiling tile and think that you're going to fix the problem. You need to find the leak, stop the leak, and then replace the ceiling tile. Otherwise, you're just spending a lot of money on ceiling tiles and getting really wet in the process. So you have to look at the body as a whole unit and how it all works together. And if you specialize in one area, then you're not going to be able to. You're not going to be able to kind of open up the scope and not narrow in one specific area. So this comes to the next point of this need for critical thinking. As healthcare practitioners, you spend years and years in school learning the fundamentals, but you rarely go back to it then. You rarely go back to that base knowledge. I know a lot of people in PT school that kind of viewed those early prerequisite classes or the early classes of PT as just kind of like okay, like we just have to know this and then we can get to the good stuff, the pathology. But people don't always fit into this perfect box. Symptom A plus symptom B plus symptom C doesn't always up into diagnosis D. You need to have that baseline knowledge and learn from it to then make your inferences of your own. It shouldn't be that if it's not in this book, then I don't understand what it could be. That is one of my biggest pet peeves when it comes to other healthcare practitioners is, well, you don't hit specific, like it needs to be this, then this, then this, and then this is your medical diagnosis. No, people aren't always like that. It has to go around in a different way. Sometimes the pathology of how they got there is different than the other person. So you need to be able to open up your mind and think of what it could be. Use your critical thinking rather than just your rote memorization to be able to assess the person that's in front of you, because that person in front of you isn't the person in the book. The person in front of you is their own person and they need to be treated in such a way. So I think that there needs to be this change of what we think of when we think of this kind of baseline knowledge that you learn in school. It needs to not just be the stepping stone for the next area. It should be what we all come up from then. That baseline knowledge of anatomy and kinesiology, and yes, you need to understand like disease processes, but more at the molecular level, the cellular level of what's happening, to then be able to bring all that information together and create what is the problem with this person that's in front of you, rather than just focusing on, I think that it is this diagnosis because it fits these symptoms. That's when you really start to pigeonhole patients and then you don't see them getting better. And this is what specialization does. You need to be able to open your mind to what the other possibilities are if you really want to affect and make change in the patient. Patients will often see me in the treatment room with my books out, with my anatomy book out. If I'm trying to figure out what is this one segment, like why do I feel something different here? What is here? Because yes, I know a lot about the body and I know a lot of anatomy, but I don't know everything and nobody knows everything. So you need to be able to feel comfortable going back to those books, back to that fundamental knowledge to help figure out what's wrong with your patient. I also take continuing education courses. I take a ton of them. I teach them and I also take them. And I think it's important that when you're first learning that you go by kind of how it's done. You learn the fundamentals, you learn the thought process, you learn the protocol that someone else created. And then once you've really learned that fundamental knowledge, then you can break out of that and start to figure out how, well, if I take a little bit from this pile of how I learn things and take a little bit from this pile, how can I combine these two to make it most effective for my patient in front of me? So you do need to learn the fundamentals. Do not get me wrong. The fundamentals are so important, but I don't think that we should take those fundamentals as just that stepping stone for learning the pathology that's in the book. We need to use our critical thinking to be able to pick and pull from those different areas to be able to pick and choose from to decide what we need to do to help our patient. This brings me to my last objective of why I don't usually care about what the medical diagnosis is. I'm really sorry, doctors, but I don't usually care because I say that if you give me 100 people with the same medical diagnosis in the room, I'll give you 100 different reasons why they got to that medical diagnosis. And guess what? It's the why they got there and the how they got there that's going to get them out of it, not necessarily a pill, at least in terms of the physical dysfunctions that I find. It's more about seeing the person in front of me and understanding that it all works together as a whole and that there can be many different causes for what this final medical diagnosis could be. So I'll give a couple examples of this so you can kind of understand. And some of these examples are crazy anatomical and all over the place examples. Don't get me wrong, like they're not the typical, but some of them are. So in the case of Beth came to me and we were talking about a lot of different things going on with her body and issues with her pelvis and her hips. And as we worked through that, we were just talking about how the body works and how it's all interconnected. And she kind of said like, hey, I have a random question for you. Like, I get UTIs whenever I get sick. And I'm like, you get UTIs whenever you get sick? Okay. And she goes, yeah, whenever I get a chest cold, I get a UTI. And I'm like, okay, well, what about like sinus cold? No, only if it's a chest cold. And then that made me think, I'm like, okay, what could be happening here that she is always having UTIs when she gets a chest cold, but not a head cold? So it's not just like that there's this infection, and the idea of having an infection is what gives her the bladder irritation that leads to a UTI. And I started thinking back into my anatomy and understanding pressure systems and how it all works together. And the fact that the pelvic floor is very much tied into the diaphragm and your ability to breathe. And I was like, it's interesting because if it doesn't happen when you have a sinus issue, but it only happens when you have a chest cold, I bet you it's an irritation of the diaphragm and the inability for the diaphragm to work properly that then is causing issues with your bladder and leading to a UTI. And that was a big ding, ding, ding for her. In terms of she had to get on antibiotics every time she had a chest cold because she knew she was going to have a UTI, but then able to work through the dysfunctions of the diaphragm, which, by the way, were helping with her low back pain and her hip issues. We need to get that diaphragm moving so that it could help the viscera move properly. Then that's going to decrease the amount of time she needs to be on antibiotics, which is better for her gut health and just better all for her health that she doesn't have to be on medications. So it was thinking outside of the box of, and investigating more rather than just assuming whenever you get sick, you have issues, you have to have a UTI. No, what kind of sickness was it? You have to kind of dive in further to understand and then figure out, what's different from like a sinus cold than a chest cold? Okay, coughing, lungs expanding, diaphragm, breathing, pressure systems with the bladder. Oh, okay, ding, 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 there we go. Another case I have is a patient, he was actually a golf pro, and he had numbness and tingling down his left arm to the point where he was going to have to stop teaching golf and playing golf because he literally had so much numbness and tingling, it hurt to hold the golf club. And understanding, like I'm treating out the neural tension. They're thinking that it's something with the first rib, but the first rib isn't affected. So I'm just kind of going through all the different possibilities. And then when we were talking about, life and when all this stuff started happening, he said that there was a big fall that he took, that he fell down some stairs. I was living in the Northeast at the time, and it gets really icy. And he actually slipped on stairs and fell right on his tailbone. And he remembers he just saw stars. And then it was pretty soon after that, he started having some of the symptoms down his arms. For him, it was, I had to treat his tailbone. And it was because of the nervous system, the dura, and how the dura is connected to the tailbone. That was the issue that I needed to treat to fix his pain down his arm, the numbness and tingling down his arm. I don't know many doctors that would have thought of that. If you went to an orthopedist saying, I've got numbness tingling down my arms, even going to the neurologist and getting nerve testing and nerve conduction, and they just couldn't figure out what the cause of it was, But then kind of diving into his history and understanding how everything's connected and how that dura, the saran wrap around your entire nervous system, is anchoring in two places. One is your sphenoid bone, the bone your brain sits on, and the other is your tailbone, aka your coccyx. How a dysfunction of the coccyx can cause an issue up higher in the arm. Another great example was actually with my clinical instructor when I was on clinical, and he's a mentor of mine too, where this woman came in and she was having headaches. And we determined that the headaches were actually caused by one of her upper vertebrae, so in her neck, was going out of the place, and it would go off to the right. And when it went off to the right, it would pinch on some nerves and it would cause her headache. So he would treat the upper cervical spine, get it sitting back to the more central alignment, and her headaches would go away. For about a week, though. So it wouldn't maintain. And if you guys have heard in my podcast or heard me speak on Instagram, I talk about this idea of recidivism, so something coming back again. So if it keeps coming back, then that means I haven't found the leak. We hadn't stopped the leak. We hadn't found the root cause of the problem. So then finally, he was like, let me just watch you walk. I just need to see how your whole body's moving. I need to understand this idea of coordinated movement. So when we watched her walk, when she stepped down on her right leg, she would collapse in through her ankle, and then her head would just ever so slightly nod to the left-hand side. So she was kind of side in bed her hand to the left. Now, she didn't do this with her left leg. So when her left leg hit, her ankle was fine and she didn't do any nodding off to the side. So then my mentor asked, did you hurt your ankle? She's like, oh yeah, actually I hurt it about 6 months ago. I sprained it really bad. It's like, okay, well, when did your headache start? Oh, about like 5 months ago. Wait, do you think they're related? Yes. So it was this idea of the kinetic chain. So here's a great idea of like this kinetic chain of, because she had lost stability of her ankle because of this ankle sprain that she had, that her foot would kind of collapse. And when it would collapse, it would go all the way up through her system to then cause her to do the tiniest bit of a head side bend, just a little bit, which then over time, over that week, would move that vertebral segment off to the right-hand side, start pinching on the nerve, and cause her headache. So for us to fix her headache, we had to treat her foot. Now, if she had just been going to the doctors and trying to figure it out, they just would have put her on pain medication. They would have given her headache medication. She would have just continued to suffer this and not understand. Or she would have gone to a practitioner that's like, oh, it's your neck, and then just keep working on the neck, but it never gets better. And it'd just be this vicious cycle of this person suffering that didn't need to happen. So sometimes you have to look at the whole body and understand how it all moves together to understand then where this dysfunction occurred from. My last example, I think I've discussed this before, but I'll say it again, is I had two patients, they were friends that had heel pain. They had plantar fasciitis. And the first person came in and was like, yeah, plantar fasciitis, and I don't know what caused it. Well, it's only one side. So if it's only one side, then I'm like, okay, it's not overuse, because I thought maybe it's because I stood a lot. And I'm like, well, if it's because you stand a lot, then I would see it happening on both feet, not just one foot. So there's something structurally that's off on that one foot that's causing pain, because if otherwise it'd be happening on both feet. So we started going through her past medical history of what could be going on. And she said, oh yeah, I kind of tripped off of a curb a little while ago, and then I guess it started, a week after that. It's like, oh, okay. So she rolled her ankle. It wasn't enough to be like a serious sprain where she really thought about it, but it was like, oh, okay. So that changed how the alignment of the bones in her foot were, which then changed the pressure that it put on the plantar fascia. So that's what caused her plantar fasciitis. So for her, I just had to work on her foot. So she was so excited about this, that someone had figured this out, that she called her friend and told her, you have to come and see Heather. She figured out my foot, because she had plantar fasciitis too, ironically, of the same leg as well. So when that patient came in, I was asking her like, okay, well, did you roll your foot? Did you this? Like, there was nothing in the past medical history that really was related to the foot or any sort of accident. And then when I was asking, oh, have you had any surgeries at all? She goes, oh yeah, I had, prolapse of my bladder, and so I had to have surgery. I had to put a sling in, but the sling is only on the left-hand side. And I'm like, oh. And so then when she stood up and I looked at her pelvis, her pelvic height was totally different on that surgical side. And then that was leading down the kinetic chain to change how her foot could bear weight through, because her leg was now kind of a different leg. It was more of a functional leg length discrepancy than a true leg length discrepancy. A true leg length discrepancy is when the actual bones are longer. A functional one is where there is an alteration of the alignment that has made it so it seems like one leg is longer than the other. So the surgery that she had led to this pelvic girdle dysfunction, her pelvis being off, that affected how her foot was able to shape to be able to bear weight through, which then put increased pressure on her plantar fascia. So here's the perfect example of give me 100 people in a room and I'll find you 100 different ways to have that same medical diagnosis. These are two people, extremely different reasons why they had that medical diagnosis. So for the woman that had the bladder sling, I barely touched her foot. I was mostly just treating in her pelvis so that her pelvis could drop down and her foot could react more effectively. So if you specialize in one area, you're going to miss out on what the possibilities are for the patient. And while this episode might seem like it's more just for practitioners, patients too, I want you to understand that it's not always good to go just to a specialist. You might need to go to someone else that's going to look elsewhere in the body. And that even goes for physical therapists. Because you could go to a physical therapist that specializes in one specific area of the body, and they're going to sometimes be just closed off and just be tunnel vision to that one area and not understand how everything interplays together and how it works to create who you are in front of them and why you got that medical diagnosis. So specialization stifles imagination. You got to stay learning. You have to stay inquisitive of what is going on with the body and how it all works together if you're really going to affect change and improve what is happening with your patients. So please don't fall into that rut, and just remember, specialization stifles imagination. Thank you for tuning in to this episode of the Body Fusion Therapy Podcast. Please share it with your friends and family, as well as leave a review if you liked what you heard today. We're looking forward to continuing this journey of looking at the body. Tune in next time.